Assalamu alaikum wa rahmatullahi wa barakatuh. Bismillah ar-Rahman ar-Rahim. I'd like to thanks Dr. Mohsen and Dr. Antonio for giving me the chance to chair in the first international course of non-invasive ventilations, which is arranged by the National Research Institute of Tuberculosis and Lung in Tehran. Thanks a lot, Dr. Mohsen. Thanks a lot to Dr. Antonio. Today my talk is about monitoring and asynchrony during non-invasive ventilation. I am Professor Mustafa Al-Shazli, pulmonary and professor of pulmonary and critical care medicine, Cairo University, Egypt. I'm also the chairman of Arab and Middle East Association for Non-Invasive Mechanical Ventilation. Today is my talk about how to monitor non-invasive mechanical ventilation in acute care settings. Non-invasive has been shown to be effective therapy for patients with acute respiratory failure of various etiologies, COPD, cardiogenic pulmonary edema, immunocompromised, and during weaning from mechanical ventilations. The main advantage of non-invasive mechanical ventilation is that it avoids endotracheal intubation with its associated complications such as ventilator-associated pneumonia and patient ventilator asynchrony and fighting the machine, and also the ventilator-induced lung injury. This is the greatest advantage of using non-invasive ventilation for early ventilatory support. However, once the decision to start non-invasive mechanical ventilation has been undertaken, it is essential to do three things: to choose a proper interface. The interface is the key to success or failure of non-invasive mechanical ventilation. So proper attention should be paid to interface and its complications, also the ventilation mode, and lastly, to plan a very close monitoring in adequate hospital location. Monitoring is another key success to non-invasive mechanical ventilation. So proper choice of NIV and how to monitor the patient is very important in acute care setting. What is monitoring? Monitoring is a systematic collection of data on specified indicator to evaluate the achievement of the objective. I have certain objective by using non-invasive mechanical ventilation, and I have to monitor if these objectives are going well or they are far beyond my dreams. What are the objectives of using non-invasive mechanical ventilation? The first objective is to unload the respiratory muscle. Second, to correct gas exchange, and finally, to improve alveolar ventilation. These are the main goals of non-invasive mechanical ventilations before knowing that the patient is in failed non-invasive or not failed. If we are achieving this goal, the patient will pass through non-invasive mechanical ventilation very nicely. If we are not achieving this, the patient will fail and we may need intratracheal intubation. So I have to monitor this unloading of the respiratory muscle and correction of gas exchange, because the failure of non-invasive mechanical ventilation is due to maybe worsening of respiratory muscle function. That is, the capability of the muscle and the load still on the muscle, and the muscle are unable to cope with the loads which has been present. In about 37% of the patient, the failure of non-invasive mechanical ventilation is due to worsening of respiratory function. Also, another very important, which is 37% is due to mask intolerance, then hemodynamic instability, deterioration in the conscious levels, and the patient may complain of hemoptysis. These are the causes. So I have to monitor those patients. So thus those factors. Thus, the response to non-invasive in the form of subjective or objective. Subjective, like I'm asking the patient if the dyspnea is relieved or not. You are now comfortable with non-invasive ventilations? What about the mental states of the patient? If the patient was conscious, is now disturbed conscious, then stuporous, this not responding, this patient is not responding. If the patient was semi-comatose and patient was delirious or agitated and now become less delirious and no agitation, this is a good response. So this is subjective. What about the dyspnea for the patient? These are objective. What about the respiratory rate? The respiratory rate was 30 or 35, now it is 25. Was 25 and now it is 35. These are discrepancies very important, because the early identification of non-invasive failure is the key also to success of invasive mechanical ventilation. It is all about timing. timing of failure if I detect that the patient is not responding well. So I do not need to prolong the period of non-invasive mechanical ventilation. If the patient is not responding well, so I have to shift immediately to invasive mechanical ventilation. So the response to non-invasive mechanical ventilation in the form of subjective or objective and physiological parameter, ECG, pulse oximeter, 24-hour, exhale tidal volume. Also the mask, very important, the mask. Fitting the mask, the patient comfort or not, if there is leak or not, and so on. Also, the muscle unloading, respiratory muscle unloading. If the patient was using the accessory muscle of respiration, or there is muscle or abdominal paradox, and now there is no abdominal paradox, and the respiratory respiratory muscle was lessened. So this degree of success. Also, and finally, ventilator monitoring. Also, abdominal distension. With the positive pressure, there may be abdominal distension and may activate the expiratory muscle. This is very important. I have to monitor the patient. So monitoring of the patient have three main domains: clinical, physiological, and NIV related. Clinical, as I said, that this year, and comfort and compliance with NIV by visual analog scale and visual and analog scale. And this analog scale from 0 to 10, 0 is least, the patient is very comfortable, 10, the patient is uncomfortable at all. This is the score, usually 3 or 4, it is better than 10. Also, if there is a respiratory stress or not, the use of accessory muscle, if there is abdominal paradox. Very important, cough efficiency. If the patient is able to cough and expectorate, this denotes that there is the airway obstruction is less, and also the forced vital capacity is effective, and the functional state of capacity is good. So we can monitor this patient is considered a success. Also, the patient is hypercapnic encephalopathy or not by Kelly-Matthew scale, and if the patient is agitated or or if the patient is agitated, I may give slight sedations and monitor the patient by Richmond agitation scale, or the patient is delirium. Very important to screen for delirium to assess if the patient is capable to bypass non-invasive ventilation or not. This is the clinical, the physiological respiratory rate, as I said before. Arterial blood gases, there is no need for arterial blood gases except after 2 hours of start of NIV. However, there is a continuous pulse. If there is continuous pulse oximeter, you have the saturation in front of you, and if there is capnography, you have end-tidal carbon dioxide continuously over you. So you do not need invasive monitoring by arterial blood gases except after 2 hours of start of NIV, or if the patient is not responding within 1 hour, you have to do arterial blood gases immediately. These are the choices. Also, ECG, there are continuous 24-hour ECG monitoring in the screen above. Also, the heart rate and the fluid balance, very important. Finally, monitoring is non-invasive relating. One of the very important is the presence of leak. Leak is an important integral part of non-invasive mechanical ventilation, because non-invasive mechanical ventilation is semi-open. Thus, leak is inherent in the design of non-invasive mechanical ventilation. I have to search for the leak either clinically and by a ventilator, as we will say later on. What about the comfort, the patient comfort? If the patient is comfortable with the interface or not, the patient or fighting the interface, if the patient has skin lesions before or not. So this will contraindicate the use of oronasal, and we may use full face mask, or we may use helmet if there is lesions in the skin. Also, patient-ventilator interaction by doing two things clinically, by comparing the respiratory rate of the patient and the respiratory rate of the ventilator, and by assessing the ventilator graphic scalar, which is patient time, flow time, pressure time, and volume time. This graphical display will give an idea about if there is auto-triggering or patient-ventilator asynchrony or not. What about the leak? Leak, very, very important. Air leak is inherent to the design. An important characteristic of ventilator delivering NIV, the ability to recognize and compensate for the leak. So newer ICU ventilator have this capability of diagnosing and compensating for the leak. Also in the portable ventilator, it is inherently in the leak. leak ability to compensate for the leak for bilevel ventilators. However, all of these ventilators can compensate for mild to moderate leak, but excessive leak will not be compensated for the. There is no ventilator that compensates for excessive leak. What is the problem with the leak? The leak will lead to decreasing the tidal volume, will lead to impairing the triggering, will lead to impairing cycling, will lead to patient discomfort and arousal from sleep and sleep fragmentations and O2B and everything. Every asynchrony beep is one of the very important items in it. So how to manage? At first, diagnose that the patient is leaking. By gross leak, you can hear that the patient easily here at the bedside. You may put your hand on the mask, and this will find you that there is excessive leak. You may hear that there is continuous leak from the mask. You may find that there is vibration in the lip or other structure indicative of air leak. If the patient is the volume time curve, there will be the tidal volume. Inspiratory tidal volume is different from that expiratory tidal volume. This is the inspiratory tidal volume. This is an inspiration, and this is expiration. This is an inspiration. Inspiratory tidal volume is equal to the expiratory tidal volume. So there is no leak. However, here there is an inspiratory tidal volume. This is the inspiratory tidal, this is inspiratory time, and this is expiratory time. Expiratory tidal volume. This is expiratory tidal volume is less than the inspiratory tidal volume. The difference between expiratory and inspiratory tidal volume is the leak. If the leak is mild to moderate, the ventilator can compensate. If the leak is severe, there will no compensation. How the ventilator can compensate for the leak? In pressure modes, the leak, the pressure in the airway is maintained. But when there is a leak, the flow will be increased to maintain the pressure. So the ventilator will not sense that the patient needs cycling. So the inspiratory time will be prolonged and will produce what's known as hanging up of inspiratory time. This inspiratory time will be increased, so expiratory time will be less, so expiratory time will be less, so there will be O2B, there will be later on ineffective effort, so and so on the cycle. So patient ventilator asynchrony will occur. This is very important and easy to detect by observing the flow time curve and the pressure time curve. How to minimize the leak? Minimizing the leak will depend on 4 items: patient, ventilator setting, interface use, and securing system of the interface. Patient, the underlying disease. If the patient has chronic obstructive airway disease, the patient may have some sort of O2 beep, so I have to put some sort of beep. Face contour. If the patient is claustrophobic, this will not. So then the full face mask will be not fitting with the patient. Maybe oronasal face mask is better. Ventilator setting. The difference between IPAP and EPAP. Even when you increase the IPAP, the leak will be more. So you have to assess this. The interface, the time, and this usually you have to accustom the interface for the face of the patient. And finally, the securing system, not to the headgear, not to use shash instead of the headgear. This will lead to patient-related asynchrony. If small to moderate leak, nothing will be done, and the ventilator will cover up. If it is large leak, that 24 liters per minute, I have to check for the interface, change the interface. If the patient is opening, I may put a chin strip. I have to assess the circuit, check the connections. Thus, proper interface type and size, proper securing system, mask support, comfort flaps. Also, if there is a rail tube or feeding tube, I have to do an adapter for the feeding, because the feeding tube will magnify the leak. If it is present, I have a hydrogel or foam seal, a chin strip in some, or lip seals or mouse tapping in some patients. These are the leak. What about patient-ventilator interaction? Patient-ventilator interaction is a major issue, or patient-ventilator asynchrony is a major issue during non-invasive mechanical ventilation and may lead to discomfort and treatment failure. Thus, The identification of patient ventilator asynchrony and prompt management is very important for the success of NIV. Because patient ventilator asynchrony will lead to discomfort, will lead to more clinical worsening of the clinical situation, thus the patient may need invasive mechanical ventilation instead of non-invasive mechanical ventilation. What is meant by asynchrony? Asynchrony is a condition there is mismatching between the patient needs and the ventilator. The patient may need the patient time may need ventilator, may need tidal volume excessive, but the ventilator will give small tidal volume according to the pressure. The patient time may need more inspiratory time, but the inspiratory time of the ventilator is less. So there is asynchrony between the patient and the machine in triggering, in cycling, in flow synchrony, and also in the beat. This is one of the studies which has which has been done in patient ventilator asynchrony in chronic obstructive airway disease in 3 hospitals. They assessed that they used ICU ventilator and non-invasive ventilators, portable ventilator, and they assessed the presence of asynchrony using EMG and pressure with flow waveform on the graphical display. Most of the patients, 40% are chronic obstructive airway disease, and near 30% have heart failure, and 15% have obstructive obesity syndrome. And they defined that asynchrony index, which is the number of asynchrony event per over total respiratory rate, and if it is more than 10%, it was considered severe asynchrony. What is astonishing that about near 45% of the patient has frequent asynchronies. And the most common form of asynchrony was late cycling and premature cycling, also auto-triggering, double triggering, and ineffective breath. So this is about 40% of the, or near half of the patients with COPD have asynchrony. And this asynchrony usually are related to 2 things. One is the interface due to leak, and the other due to the ventilator setting, which is the level of the pressure support. Interface is the key to success or failure of non-invasive mechanical ventilation. So I have to adapt the interface for the patient. And there are multiple interfaces like face mask, oronasal or full face mask, or helmet mask. One important item is that nasal mask is associated with excessive leak. It does not fit acute care setting. In patients with acute respiratory failure, do not use nasal mask. Use oronasal or full face mask or helmet mask at some time. Do not use full nasal mask. How to monitor patient ventilator asynchrony? Very simply, by clinically. If the patient is tachypneic, if the patient is there is activation of inspiratory muscles, ineffective triggering effort, this will be observed on clinical, and this patient is fighting for the machine. And I may use ventilator graphical pressure time or flow time or volume time to detect the leaks. These are the breaths, the phases of each breath, which is triggering or pressurizations and the level of pressure support, and then cycling, and finally the beat. So there may be trigger asynchrony, there may be flow asynchrony, there may be cycle asynchrony, and the level of the beat finally is very, very important. This is the patient start to take an inspiratory breath, and this is pressure time curve, and this is flow time curve. This 25% of the peak flow rate, the patient cycles into expiration. But here there is something which is astonishing, that the patient, there is inspiratory hanging. The airway pressure does not decrease. The peak flow rate does not decrease to the cycling level. This is due to leak. This is what's known as inspiratory hanging. It will lead to increased inspiratory time, more than 4 seconds. And this is inspiratory hanging due to excessive leak. I have to change the parameter, as we will say later on. This is leak. What about auto-triggering? Auto-triggering may be that the ventilator give breaths not due to the patient. It occurs when there is absence of any muscle contraction. It can be occurred by low triggering threshold, or the sensitivity is very low, or excessive leak, or present in water in the circuit, or cardiogenic oscillations. This is How can I detect? By the absence of patient effort at the beginning of inspirations. Usually the character of pressure time curve, it is shorter and the peak inspiratory flow is lower in comparison to patient trigger breath. This is here, there is a flow time curve, the flow occur. This is the patient start to take negative pressure. Then this is the EBAP, this is the IBAP, normal, and this is normal. But here there's absence of patient activity, and this is some sort of auto triggering, and the change is lower in the peak pressure and more spike. This here is another one. So this is short cycle with flow distortion, and here by EMG there is no drop of the pressure, no patient effort on the EMG. This is the auto triggering. Excessive trigger delay, the patient may need to start the inspiration, but the ventilator take time more than 300 milliseconds to respond to the patient. This is one of the parameters of qualifying the ventilator from one to another. Ineffective effort, very, very important, because the patient tried to open the ventilator, but the ventilator does not sense the patient. Not delayed, but does not sense the patient. This is, so the patient here tried to take a negative pressure, and here is change in the flow, but no actual flow time or delivery of pressure and delivery of tidal volume. Here, the patient, this is transdiaphragmatic pressure or the transdiaphragmatic pressure activity, there is activity of the patient, but no air pressure time change or flow time change. This is ineffective. How can I assess? By clinically, by observing the respiratory rate of the patient. If the respiratory rate of the patient is more than the rate that the ventilator gives, this is the patient is trying to do effort, but the ventilator does not respond. So this ineffective effort also. So I have the most common cause of ineffective effort in patients with chronic obstructive airway is the presence of O2. Also, asynchrony. Sometimes the flow after the sensing that the trigger, the flow delivery, sometimes it is so rapid that the change from EBAP to IBAP is very rapid. This may lead to flow overshooting. And this is the picture that in the pressure time curve, not in the flow time curve, in the pressure time curve, there is a peak in the start. This denotes that the rise time is very small or very rapid. So I have to decrease the rise time, as we will know later on. So too fast inspiratory flow, more discomfort and overshooting. So I have to decrease. This is the discomfort. So I have to decrease the flow, the rise time from 100 to 200 or 300 milliseconds to adapt for a normal evolution of patients. Also, during cycling, during this beacon, sometimes the peak inspiratory flow will give an idea about the magnitude of the patient effort or the presence of airway obstruction. If the presence of airway obstruction, the pressure will be fixed, but the flow will decrease. So this is change in the airway. This is the change in the airway obstruction. By changing the peak inspiratory flow rate, I can know that this patient experiencing airway obstructions. The patient is fighting the machine, so I have to give bronchodilator or steroid and something. Finally, during cycling, either early cycling, that is to say that the patient inspiratory effort is prolonged, the patient is inspiratory time is long, but the machine time is small. So the patient needs more tidal volume, more pressure than that the ventilator allows. So this is end of inspiratory time by the machine, but this patient start to take deep another breath. If taking another breath is severe enough, the patient may enter into double triggering. Also delayed cycling, that is to say, the patient have ended his own inspiration and needs to expire, but the ventilator doesn't allow the patient to expire. So this will lead to peak in expiration in pressure time curve at the end. So if there is peak of pressure time curve in the early, this flow overshooting. if peak in pressure time curve in the late, this is delayed cycling. Delayed cycling have to decrease inspiratory time. Which beep level is the best beep level? Most patients with chronic obstructive airway have some sort of auto beep. So this auto beep is usually intrinsic beep 6 plus 3 centimeter water. So I have to put an expiratory or EBAP from 3 to 5 centimeter water, and this is will improve two things. First, will improve the auto beep, dynamic beep, because patient with chronic obstructive airway disease has an auto beep. Second, it will help to prevent rebreathing of carbon dioxide rebreathing, which is very important. I think that one of the important ignored thing is the presence of obstructive apnea in patients presenting with type 2 respiratory failure in the ICU for the first time. Usually, use of non-invasive, the beep is that when there is obstructive sleep apnea, the beep must be from 8 to 10 centimeter water. Very, very important, because the patient have an obstructive airway disease, obstructive sleep apnea. If we didn't use this, we are under ventilating our patient. Because this one of the study which has been that there showed that there is a high prevalence of sleep apnea in patients admitted to the ICU for acute hypercapnic respiratory failure. It included 35 patients, but actually it revealed 16 patients which have been done complete polysomnography and pulmonary function after 3 months of discharge. And they found that about 56% of the patients, 56% of the patients have severe obstructive sleep apnea, and about 50% of them, 50% of the patient has obstructive ventilatory pattern. So if I just only did pulmonary function test, it will reveal that 50% just have obstructed, and about 50% will not be designed as obstructive sleep apnea. So finally, how to improve by patient ventilator asynchrony, by patient examination, by patient interviewing, examination of the ventilator setting. But after a ventilator adjustment, you have to assess the patient by patient examination, subjective level of dyspnea, comfort, and careful assessment of the ventilator waveform. And finally, the mini-invasive, the underlying physiology is dynamic, so frequent manipulation of ventilator setting is very important. So if there is trigger asynchrony, adjust trigger sensitivity. You may increase the beep ineffective effort to overcome the auto beep, minimize unintentional leak, treat the underlying disease, use pressure targeted or volume targeted ventilation according to patient comfort, adjust inspiratory pressures. Finally, adjust the rise time, as I said, not too slow, not too high, minimize unintentional leak, reduce the respiratory time. Finally, cycle asynchrony, minimize unintentional leak, use time cycle and duration cycle. My final recommendation, my final slides for adjustment of ventilator setting: inspiratory trigger 3 liters per minute to minimize auto triggering, inspiratory flow or rise time around 200 milliseconds or sometimes 300 to avoid overshooting. Pressure support level start with 5 to 7 centimeter, which is the difference between IBAP and EBAP. This is the difference between both in the pressure support level, and increases gradually to the target tidal volume 6 milli per kg. And take care that high tidal volume patients with de novo acute respiratory failure may lead to ventilator-induced lung injury. And finally, the beep level normally 3 to 5, usually 4. And in patients with you suspect obesity, hypertension syndrome, obstructive sleep apnea, give 8 to 10 centimeter water in patients with those with ARDS. If there is a leak, you have to adjust the interface. You have to delay the inspiratory flow rim, decrease the pressure support. But if I decrease the pressure support, decrease the IBAP, I will decrease the EBAP, but not the EBAP will not be less than 3 centimeter water. And finally, increase cycling value from 25 to 40%. And in newer ventilator, you have multiple options to monitor, not just like ventilators which you just monitor the patient clinically. So during NIV close monitoring is very important to optimize therapy, minimize complication and risk of treatment failure. Essential monitoring should include regular evaluation, continuous ventilator display. In the last decade, significant technical advances in the ventilator and interface has allowed detailed monitoring to decrease the leak patient ventilator synchrony. And thank you. شكرا جزيلا لكم والسلام عليكم ورحمة الله وبركاته.